Good morning, everyone. Welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for another session. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's discussion. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box for our record-keeping purposes. Please stay muted unless you're speaking. You may also use the chat for communicating. Feel free to unmute or use the chat when you have questions or comments. We will be monitoring the chat throughout the session. We realize that the Q&A time is very important, and we try to categorize and address as many questions as possible. If you have questions today that aren't answered, we encourage you to submit those as a possible case discussion item at a future session. And remember, the link to submit cases is included in the follow-up emails that we send out, and you can always contact us directly at echo@psu.edu. Please remember, in any of our cases, there is no personally identifiable information allowed. And we are recording these sessions, and after every session, we will share the materials and recordings. In the spirit of all teach and all learn, we're on a first name basis during the sessions. Our sessions, our Echo sessions always begin with a brief lecture followed by a case discussion. Cases could be a question, a challenge, whatever you would want to address. They're a critical component of the Echo model, and we really encourage you to either email us or submit any types of patient-related preparedness policy questions or cases for our discussions. For today's session, Dr. Aditya Joshi will discuss mental health concerns during a pandemic. And since we don't have submitted cases, he has several case scenarios that he'll walk us through as well. During the lecture, again, please feel free to put your questions into the chat. We will stop throughout so that we can address those questions. We do have a team of specialists from Penn State that stay online and help field our questions. But remember, this is all teach, all learn, so everyone can share both questions and answers. And with that, I am going to turn things over to Dr. Joshi for our brief lecture.
One wave. Okay, I think that's fine. So I'm with the Department of Psychiatry here at Penn State Hershey, and I'm going to be talking a bit about mental health concerns that you might be called upon to deal with as a result of the ongoing pandemic. And I cannot seem to forward these slides. We go to, thank you. So I have a couple of learning objectives for this session. The first one is to just familiarize you with resources that are available to you to help people help people deal with the impact of the pandemic, and more importantly, to give you a sense of how you could use those resources to tailor interventions particular to your specific patients. So what I'm going to do is I'm going to give you a bit of theoretical background, and then I have a number of case vignettes which will help illustrate some of what I'm going to be talking about. So the first question is, what kind of things do we look out for in a situation like this? I would say you probably want to be on the lookout for two kinds of things: people who come to you with newly developed symptoms, and you may also want to look out for people who have a history of pre-existing mental illness, in which case you might see their symptoms worsen. The kind of symptoms to look out for would be anxiety. I would expect would be a very common presentation. People might present to you with signs and symptoms of depression. Essentially, they might be finding themselves more tearful than usual. They may not be enjoying things as much as they usually did. And other symptoms, which would again be warning signs, things like disturbances in sleep patterns, changes in appetite. People may tell you that they find themselves more irritable, have more difficulty than normal focusing on tasks. Another important thing to look out for would be an increased use of alcohol, tobacco, or in some cases, illicit substance abuse. So what do you do when someone comes to you complaining of these symptoms? Well, as part of your assessment, obviously, you may want to look at the nature of symptoms. Are the symptoms transient? Are they present all the time? Look at any aggravating or relieving factors. Look for associated symptoms. So if someone comes to you talking about feeling depressed, you may want to ask them about other symptoms that might be part of a depression-like picture, like disturbances in sleep, appetite, increased irritability, As part of your mental health assessment, you may also want to build in some kind of a safety assessment, which is essentially you assessing the patient's suicide risk. So a good screening question to ask with these patients can be, have there been times when you may have felt that life is not worth living anymore? And depending on what that question yields, you can then go on and ask in more detail. So once you have some kind of a brief assessment in place and have that information, you can then tailor interventions based on the patient's needs. So let me tell you a little bit about the kind of resources you can bring to bear on these sort of problems. The first concept I want to talk to you about is that of psychological first aid. So this was an intervention that was initially conceived for use in the immediate aftermath of a disaster. Think a hurricane or a tornado ripping through a community, a huge terroristic action, which leads to destruction and death. There are lots of components from this intervention that can actually be used in this kind of a scenario, and I will talk briefly about these. So what psychological first aid basically aims at doing is enhancing the feeling of safety and comfort in the immediate aftermath of a disaster, where you assess the patient's immediate needs and tailor specific interventions, practical interventions, to be used just in that scenario, not so much in the long run. Another concept the psychological first aid touches upon is to provide people with what are called adaptive coping skills. These are skills they could use to get themselves to a better spot, as opposed to skills which would be considered maladaptive, such as drug and alcohol misuse in the context of a disaster. There's a very good field operations guide available online as far as psychological first aid is concerned. I've put a link to that on the list of resources that might be available on PSU Box. I would encourage all of you to download it. It's freely available and go through it. It does not take too much of your time to actually flip through the manual, and you will come up with a lot of practical skills you will be able to implement in everyday life very quickly. You don't need extensive training to be able to do that. But to give you an example of the kind of things you could do, when you talk about enhancing a sense of safety and comfort in this particular group of patients, that could be providing them with accurate information about what's going on, giving them a sense of what's being done in response to the problem and what kind of resources are available to them. Counseling them about self-care. And I would actually maybe even link point number 7, giving them information on coping, which can be in different types. Knowledge is a very powerful thing in these kind of scenarios. So you may want to talk to them about what a typical stress reaction might look like. So in response to stress, you can counsel them on the kind of symptoms that might present, so that these people don't feel overwhelmed when they do experience these symptoms, particularly things like increased anxiety, panic attacks. People can have hypervigilance, where they might be very easily startled by certain cues, or they might find themselves avoiding certain things. Just knowing that these things can happen will help them recognize these issues when they come up and do something about it. Other coping adaptive skills, I would encourage my patients to stay informed, but get information from reliable sources. I think you've probably heard experts mention a bazillion times, and I will add to that, have patients be informed, but maybe counsel them against binge watching the news, and take a break from time to time, and not get overwhelmed by the flood of information that's coming towards them. Encourage people to talk to others, people they trust, friends, family members, counselors they know of. Remind them to stick to a regular schedule. There may be many situations in all of this that are beyond our control, but there are some things we can control, and reminding patients of the kind of things they can control helps restore that sense of normalcy. The importance of adequate rest and nutrition, taking breaks, relaxation techniques like deep breathing exercises. Again, they're all part of the field operations guide. Some people might find themselves getting angry a lot. So teaching them basic anger management techniques, which would include helping them identify signs and symptoms of anger, and then intervening so that they don't escalate to the point of becoming a problem. The other thing you want to do as part of psychological first aid is get a sense of the patient's immediate needs and give them practical assistance in terms of what they might need in that setting, and connecting them with other resources that are available at that time. So that's kind of psychological first aid in a nutshell, and we'll come back to it in a little bit. The next thing you could do in terms of the treatments and help you can offer is educate. Again, as I said, there's a lot of information going around. Not all of it is true. So you could do your patients a great service by directing them towards reliable sources of information. Now, all of these resources are on that resources document that's available to you, but I will just highlight some of them. So the CDC has very, very good guidance on managing mental health. Mental health issues that might crop up during this time. If you're worried about your patient's safety, you can direct them towards the suicide prevention hotline. The American Psychiatric Association has set up a resource center for mental health related issues, and these are directed towards providers, towards patients and their families. Again, a huge treasure trove of information, as does the American Academy of Child and Adolescent Psychiatry. And again, some of this information is kind of repeated across various websites, but coronavirus.gov is again another decent source of information to turn to. Now, in terms of other interventions, obviously people think of symptoms that might come up, and the most obvious question that comes up is, what medicine can I use? And remember that medicines are an option, but medicines aren't necessarily the only option you could use to help people with ongoing issues. And even in terms of medicines themselves, as part of your assessment, you may want to think about whether any medication or pharmacological option should be used on a long-term versus short-term basis. And that would really depend on the nature of the symptom. So if someone's had a symptom that is relatively new and relatively transient, maybe an as-needed medication might be a better option as opposed to a patient where they have a history of a mental health illness and the current scenario has resulted in a worsening of their symptoms. But I would also encourage you to explore non-pharmacological therapeutic informations, relaxation techniques, deep breathing exercises, grounding techniques, which are all described in the field operations guide. You could direct people towards virtual resources. So there are a couple of websites that your patients might find helpful. There is virusanxiety.com and Headspace. Both of these actually offer meditation/mindfulness exercises. And some of them are available without cost. And again, these aren't the only resources that are available, but these are some I knew of, so I wanted to point you in that direction. There's also a very interesting document on how you could deal with anxiety that might crop up during this time period. And a lot of these resources were actually shared with us through the Office of Professional Mental Health at the College of Medicine. So I would like to acknowledge them for all their hard work. Okay, so now that we have some idea of the kind of things we can possibly do, let's see, how we can implement that information. So before I move forward with the case scenarios, does anyone have a question, or would anyone like me to clarify anything?
Someone did mention that Headspace is free for healthcare providers. So I would encourage anyone who knows of free resources or has had experiences with them to please go ahead and share them in the chat, and we'll continue to gather those. But are there any specific questions before we move into the cases?
Okay. So you're right, Headspace is free. I think what they may want to get from you is your NPI number before they allow you access to their resources, but it is free to clinical providers. So let's quickly go through case one. And this is something you may have already run into or are probably likely to run into. This could be a friend, a family member, or a neighbor who stops you and expresses concern about his 19-year-old son's well-being. The son has recently returned home after the college shut down and has frequently expressed frustration at not knowing what's going on. There's been conflicting information about the pandemic via various media outlets, which is added to to his overall distress. So he's confided in his father that there have been times when he's wondered if it would be better if he weren't alive, but he has assured his dad that he has no plan or intention of ending his life. So your neighbor obviously acknowledges a feeling of helplessness and asks you for your help. I would just be curious in knowing, knowing what we just spoke about, what kind of resources would be best suited to this condition? I have a sense of what I would do, but it would be helpful for me to know what the others are thinking too.
So, hi, my name is, can you hear me okay?
Mm-hmm. Yes, we can.
Okay, thanks. So my name is Erica Hasser, and I'm the project director with Age Friendly Care Pennsylvania at the College of Nursing. My background is more in human development, pardon me, the background in psychology, and I would think that maybe helping this person, reminding this person that there are so many things, only so many things that they can control, that would be sort of my first reaction, is to remind them to think about the things that they are able to control.
Right. So I think what you're alluding to is some of the concepts of psychological first aid. Now, obviously, in this scenario, we don't have the person in front of us. So the information we're getting is basically through secondhand sources. And I would agree. And if you look at the options on the right-hand margin, it mentions 3 broad different categories of options. Remember, treatment options aren't necessarily a zero-sum game. You don't have to only pick one. It could be a combination. And in some cases, you may want to focus more on one modality than others. So at this point, this is someone where I wouldn't probably be inclined to rush in with a prescription. But I think at least dealing with the father, giving the father information on what kind of resources might give the son the best bits of information. And pointing them in the direction of the non-pharmacological interventions like the mindfulness exercises might be a more helpful thing. And as you said, if the 19-year-old was in my office with me, I would probably roll out the full suite of psychological first aid actions. And again, just to elaborate on some of the very simple techniques you can counsel your patients on: deep breathing exercises, asking the patient to breathe in very slowly, maybe, doing 1,001, 1,002, 1,003 count when they're doing it, holding it for a second or two and exhaling at the same count, with the idea being that they're focusing on the breath going in and out of their body rather than everything else that is swirling around in their head. Another technique that is very, very simple and effective can be what is called grounding, which basically, in a nutshell, is that sometimes people can be so caught up in their emotions that the thoughts themselves are overwhelming, and grounding breaks that cycle by just bringing them back in touch with the environment around them. So telling the person to kind of sit themselves up in a comfortable position and asking them just to maybe point out to 5 things they can see in their immediate vicinity which they don't find threatening, or 5 things they can touch in their vicinity which are non-threatening. These sound like very simple interventions, but they tend to be very effective. So that's what I would do. Now, as part of the suicide risk assessment, I think this is very important, and this is something that non-mental health providers tend to find a bit scary. If that patient was in front of me, I would probably want them to elaborate on the thought of not wanting to be alive. So the thought of not wanting to be alive would usually fall under the category of what we refer to as a passive death wish, which would obviously concern me. But a follow-up question could be, when you've had these thoughts, have they ever progressed to the extent of you actually wanting to end your life? And if that's the case, you ask them if they have a plan or an intention of acting on them. So that would form part of a broader suicide risk assessment. At this point, what I would do is I would probably give the dad the suicide prevention hotline number. At least in Pennsylvania, pretty much every county has a crisis intervention service, which is a 24/7 service available to residents of specific counties. You could pass that information along to friends or family members.
Deidre has a question in the chat. Would you, in this scenario, offer to speak with the son?
Sure. So Absolutely, that would always be an option. But if you actually have a chance to go through the first aid field operations guide, one of the things they talk about, the first point they talk about is letting people know that you're there for help, but not trying to impose help upon them if they're not willing to receive it. So timing is everything. At this point, and again, this is very limited information, but I'm not sure how helpful the patient would find it or this person would find it. I'm assuming he's a patient, he may not be. For me to just randomly cold call him and say, I'm so-and-so, do you want to talk about this? That may not go down very well. So yes, you offer them all options, but then you let them decide if they want to take your offer up.
We also have we have a few comments. So someone shared a resource called Warm Line with a phone number for that. So if someone needs to talk to someone, they can call and speak with a mental health provider over the phone. And then another comment, someone loves the open-ended probing phrase, help me understand. It's a safe way to begin to explore underlying issues and concerns.
And I must repeat that actually all these case scenarios that I'm presenting are based on real life stuff that I have encountered over the last few weeks. So I hope that lends it some kind of credibility. I'm clearly not making this stuff up. Okay. If there aren't any more questions about this one, let's move on to the next scenario, which is okay. So what can we do to help this delightful 72-year-old lady? So she has a history of depression and anxiety. Her symptoms have actually been very well controlled on a medicine called sertraline, which, if you're not familiar with, is an antidepressant. She calls you to ask for a prescription of lorazepam to use on an as-needed basis. She denies persistent anxiety, but admits to intermittent anxiety secondary to the recent pandemic. She prides herself on being very well informed, and has been devouring news from every source imaginable. She's been on lorazepam in the past, and while this medication has helped provide her with some relief, it was discontinued due to multiple falls. The falls have led to at least 2 emergency room visits in the past. There is no history of prescription medication or illicit substance misuse. How would you best approach this scenario? So again, our options are, do we hit this person with more medicines? Do we kind of educate and familiarize with resources, use non-pharm interventions, or a combination of?
Do we know anything about her mobility status?
She's able to ambulate on her own. And the patient tells you that at least as of this point, mobility isn't an issue. There have been no recent falls either.
Aditya, it's Ted Bollard checking in. Being a primary care provider, knowing that lorazepam and all benzodiazepines are on the Beers list of medications not to use, particularly given her history of multiple falls. I mean, I think you have to look at all other resources to help with her, whether it be cognitive behavioral therapy, whether it be other therapies she can do at home, but certainly adding benzodiazepine to her is not the right thing.
Right. So actually, I'll tell you what I did. We decided not to prescribe her lorazepam, and we kind of did shared decision making. I reassured the patient that I was not necessarily worried about her misusing this medication in any way, but I shared my concern that because there was a historical precedent of her having had falls on benzodiazepine, especially with ending up in the emergency room. We discussed the risks and benefits, and I even discussed a hypothetical situation of, well, even if we use half the dose of lorazepam you were on in the past, that still puts you at a high risk of falls. And we discussed the possible consequences, one of which was, do you really want to be spending time in an emergency room at this time with the pandemic raging? And the patient decided that they didn't necessarily want a benzodiazepine in that instance. So, as a provider, this is a very nice, non-demanding patient. And, part of me going into the conversation was worried about, what if she says, give me benzodiazepines or give me death? What do I do then? And that is a concern I suspect most of you will have going into these conversations. But you know, with a robust discussion of what the possible benefits were, what the possible risks were, we decided that a benzodiazepine may not be the best option. Now, I did explore the nature of her symptoms, and actually in real life, it had turned out that the anxiety wasn't necessarily intermittent, and we figured that we could safely manage her persistent increase in anxiety by just you know, tweaking around her existing medicines. And the patient was okay with that. I haven't heard back from them since, so I'm assuming that things worked out well. But actually, this particular case is an amalgamation of two different scenarios. The other scenario was this person who has a history of mood disorders who'd been doing relatively okay, but called us to say, look, I'm having anxiety. I find myself a little bit irritable. Could you add on another medicine? And I was reluctant to do that because in this case, the past history was of bipolar disorder, and adding an antidepressant would mean I would run the risk of destabilizing this patient. So we explored the symptoms, and this stuff just takes a couple of minutes. You know, this isn't heavy duty Freudian psychotherapy. I just said, tell me about your symptoms. What brings them on? What relieves them? Well, it turns out he was devouring the news and was getting riled up by everything he was hearing. You know, so the simple prescription was, well, stop watching the news, or at least, you know, don't binge watch the news. Maybe go for the Netflix shows instead. Again, something that worked out very well, something the patient felt was a very reasonable intervention to use. And of course, you know, we also pointed them in the direction of the other resources. So again, you know, you may differ in your management of these patients, and that's okay. You know, you could theoretically approach these scenarios with a different viewpoint. My goal is just to help you develop your thought process specifically with the context of mental health issues. So that's kind of what we did.
Generated a lot of questions and comments.
Okay.
Can you address some of them for us?
Absolutely. I cannot actually read any of those. If someone...
I'll share them with you, okay? Trying to group them together. So there were a few things related, a few questions just to better understand the scenario. Does she have in this case, does she have a support system, family, etc.?
So great question. In real life, no. You know, this is someone who's been widowed for a few years. There's not a lot of family around.
Okay,
but I would have thought of those as support systems, as, you know, in terms of people they could call up, making that 3 a.m. phone call if they needed to in times of distress. But I'm glad whoever it was thinking of it in that way.
And does she have structure in her day? I know you mentioned some of the binge watching, but does she have any type of structure?
You know, I would counsel them on having that kind of a structure. So I can think of another recent you know, conversation I had with a patient of mine who actually has an established diagnosis of post-traumatic stress disorder. And the patient spoke about this incredible lack of control over recent events. And we said, well, and we actually in that scenario did make some medicine changes, but the larger and broader conversation was, well, what's really getting to you is this loss of control. Let's sit down for a few minutes and talk about the things you do have control over. How could you then regain control? And it turned out that the person could regain control over, you know, they were going to sit down and make a daily timetable for themselves, which they were going to try and adhere to as much as possible. Taking the dog out for a walk in their yard, if not, you know, in their development, and so on and so forth. So yes, that would be a part of a lot of my conversations. In this lady's case, she was actually following most of those things, so I didn't necessarily harp upon those points. But, you know, would it hurt to remind her of them? No, it didn't. I just know that she was doing it, but I will give myself a slap on the wrist for not reviewing it with her.
Thank you. Another comment that came out, and I think it raises a really big issue, that older adults in rural America are challenged with lack of internet or reliable access. So how does that factor in, or how would you address that situation?
That's a tough one, isn't it? I think the phone could be your friend in that instance. You know, having an identified source of support. So with some of this, and again, I've discussed this case in isolation, but when these people would have presented to me for the first time, I would usually go through a crisis management plan with them in terms of, help identify in advance who the people are they could call in the event of an emergency, or even if they weren't feeling very well. And actually, as part of my risk assessment, we're kind of in a semi-rural area where a lot of people hunt. So, as part of my initial risk assessment, I actually, if I'm worried about their safety, I kind of say to them, look, why don't we call a trusted friend or a family member who can hold on to your firearms till you feel safer. And again, if you do it in conjunction with the patient, they don't necessarily find it threatening. I've not ever received pushback on that suggestion. So you really want to be broaching that topic with a certain degree of sensitivity, because it can stoke a lot of passions one way or another. But I would add that to your management thought process, especially with people living in a more rural setting.
So there are also a few questions and comments regarding a pharmacy approach to this. So someone had mentioned, Mark Stevens mentioned that he's been cross-covering multiple colleagues over the past few weeks, and opioid and benzo refills come across regularly. His opinion is that these medications have limited short-term benefit with potentially multiple long-term complications. So in this case, he would lean towards not refilling.
Yep.
Is that something?
Yep. So in this case, actually, we did not refill benzos, and I agree with Mark. I mean, the request for benzos is more common than you would think. I use my best judgment as much as possible. I try to steer patients away from benzos just for the reason Mark mentioned. For some people, they can cause more harm. So if you look at the VA's PTSD management guidelines, they would actually advocate against the use of benzodiazepines, especially for patients who have a history of PTSD. For this lady, who was 72 years old, the worst thing I could have possibly done was given her a medicine that would have led to a fall, a cracked skull, and a visit to the emergency room where she'd be more exposed to pathogens. And one of the things I also like to tell people is that, look, this is a stressor, but there will be more stresses in life. And do you really want to be reaching out for a controlled substance every time? How about we help shore up the bench and give you more resources? Have you tried deep breathing exercises? Have you tried grounding techniques? Have you tried meditation? Have you tried talking to someone? And for most part, those interventions work. I mean, I will admit I have written a few benzodiazepine prescriptions, but with these techniques, they've thankfully been few. And again, you assess the scenario, and if you do a risk-benefit analysis and decide whether a prescription would be a good option or not. Now, obviously, if this person had a history of prior substance misuse or alcohol use, then and I've said this to patients very, very candidly. I'm not going to prescribe this to you because I frankly do not want to end up replacing one problem with another one. And for most part, they've been okay with that line of thinking. I think as long as you give them the impression that you're doing something to help, most patients will be okay with that.
So somebody else, I'm trying to get one of our questions shared through the audio, but while that's being addressed, Kelly, and I know Kelly is coming from Broadtop, I believe, and she said we may need to pay attention to withdrawal issues in persons who've been regularly taking opioids, benzos, or using alcohol regularly. And we are actually going to be having a session, I believe, next week addressing opioid use throughout this pandemic. So do you have any follow-up for that one?
Yes, and that can be particularly tricky, right? What do you say to someone who says, my supply of alcohol is about to be cut off because the governor's shut all stores down? Well, that's a really tough one. If it's an alcohol thing, the best medicine essentially to detox someone from alcohol would probably be a benzodiazepine. But the really important part is, do you really want to prescribe a benzodiazepine for someone in an outpatient setting, particularly when the detox is not going to be supervised? for something like this, the conversation may have to be, look, I'm glad you want to cut down on your alcohol use. At this time, maybe you may want to just start tapering off the amount you're consuming. So instead of 2 6-packs, maybe cut it down by a drink every few days and taper yourself off to a softer landing. SAMHSA actually has some resources on their websites about non-benzodiazepine options that could be used to detox patients. I haven't put it on a list of resources, so they talk about the use of gabapentin, topiramate, and I think carbamazepine was the third drug. In the interest of full disclosure, I'm aware of those studies, but I have not read them in full detail in the sense that I don't know how much alcohol these people were consuming. So you have to think, is this person drinking or trying to detox themselves from a 6-pack a day? The management of that would be very different than someone who's drinking 2 bottles of vodka a day. So you have to kind of factor those things in mind. But that is a very tough scenario. And sometimes, my advice would be cut down slowly with the intention of stopping it. Don't do it immediately. But offer them practical solutions.
Dr. Joshi, this is Tim Weaver in family practice in Millersville, Penn State Health Manor. I had a question to consider for this patient. If they're really pressing for medications, would you consider hydroxyzine?
Yeah.
I know it has its own concerns there, but that might be a softer landing.
Absolutely.
The other thing that I had a question about is how concerned are you about hydroxyzine and Celexa use in combination as far as like the QT prolongation concern and that kind of thing?
So just to go back to Tim's question, I'm assuming, Tim, you're talking about using hydroxyzine in the context of an anxious patient, not to detox someone from alcohol. So,
yeah, sorry, going back to the
I just wanted to clarify to the rest of the audience. So hydroxyzine is a non-benzo option. I would actually, a lot of times when I'm reluctant to use a benzodiazepine, hydroxyzine is my go-to drug. Again, now specifically in the context of this lady, you may want to just bear in mind that we would then possibly be exposing this person to anticholinergic side effects. So you can to avoid that, you can start at a relatively lower dose. For most adults, I try to start off with 50 milligrams as needed. But if you're worried, for someone like this, I would maybe go initially with a 25 milligram dose. Second question about could it potentially bump up a QTC interval to beyond that dreaded 500 millisecond mark where they're more vulnerable to then arrhythmias? I would look at the patient's history. So sometimes you can find an older EKG to look at, and if the QTC interval is traditionally been okay, I'd be less worried about it. If it's someone in the gray zone, so this is a female patient, if there's someone in the 470 to 500 millisecond zone, you could technically get another EKG in a few days after you started treatment, maybe after 3 to 5 half-lives. But again, you're then requiring the patient to get out of their home in a clinical setting where they can potentially be exposed. So for patients where they don't necessarily have a history of QTC prolongation, I tend not to worry too much. Where they're in the gray zone, it's kind of a judgment call. Certainly, if the QTC is flirting with the 500 mark, I would avoid it.
Thank you. Thanks.
Thank you, Tim, for sharing that. Are there any other questions on this case? Feel free to unmute if you have any. And if not, we could go to your third case because I think that is a different spin on it.
Okay. So the third one, okay, I'm sorry, we just skipped to the last slide. Okay, so how would you approach this particular situation? So this is a 48-year-old gentleman with chronic anxiety and depression. And he comes to your clinic for an urgent visit. The symptoms, which had been in partial remission prior to the pandemic, have worsened in recent times. He's been anxious and dysphoric with occasional thoughts of self-harm. So in this case, this would be what I would classify as active suicidal ideation. But as part of the risk assessment, This person has no plan or intention, and he's clearly sought help. And he was seen by one of your colleagues for an urgent visit, but left unsatisfied with the outcome of the appointment. And he tells you that your colleague counseled him that, well, everyone's anxious nowadays, which isn't necessarily wrong, but he was directed towards the CDC website. So your colleague has obviously followed some of the recommendations we spoke about. And the patient complains to you that he feels his concerns were unfairly minimized and dismissed. So, take a moment to think about how you would approach this patient. While you are thinking, let me just plant another seed in your mind. For those of you who are not very familiar with the concept of suicide risk assessment, there are some resources out there. I think most Hershey Medical Center providers, at least at some point in the last few months, were required to do the risk assessment training. But there is a very interesting tool, or a helpful tool, called the Columbia Suicide Severity Rating Scale, which just helps you organize your thoughts in terms of the questions you may want to ask to figure out if the patient is at low risk or particularly high risk. That is freely available to use, and they actually even have online training for those who are interested. I just thought I would throw it out there. But coming back to this particular scenario, again, I would love to hear your thoughts on how you might approach this.
Hi, it's Andy Probolis. The question that I usually ask when I'm dealing with a situation like this is kind of trying to get a better sense of what he was looking for, what was he expecting, and I think that sometimes can be a really helpful kind of follow-up question to try to get at what feels unsatisfying, what was he really looking for.
Right, and I think that is you've hit it right on the head. So just to give you some background about this patient, and because we had limited real estate, I couldn't put that much. This is again a patient of mine who I've known for a number of years, who is actually very insightful about their signs and symptoms. This is not someone who asks me for a medicine change at the drop of a hat. Clearly not someone who's misused substances in any way, is not looking to get high on medicines. So this would be a scenario where you're having to deal with a person who actually has a history of mental health problems. And it's very likely that some of these symptoms will flare up in the current scenario. I've had people come to me with worsening of their anxiety, depression, PTSD, OCD. Their psychotic symptoms, which are very well controlled, have flared up. Now, obviously, all the treatment modalities could possibly be helpful, but yeah, I would ask the patient, tell me, can you think of anything in particular that might be helpful? I asked him that question with the understanding that I may not always agree with their suggestion, but I certainly tell them that I would keep that into consideration. So now this patient is generally well informed, has actually already been counseled about, where they can get information about the pandemic, and actually, had a fair understanding of what was going on. So we actually decided to do two things. I provided them with, I think, with a mind space. I directed them in the direction of that, and they said, look, could we also possibly, make a medicine change, which was not unreasonable. So we certainly did not go for a benzodiazepine. But when we looked at this person's medication regimen, we realized that there was leeway in terms of, I had the ability to make changes to some of the existing medicines. So we just tried to optimize symptom control by making changes to the existing medication regime. So again, kind of brings me back to what I said earlier. It doesn't have to be one or another. It's helpful to get a sense of what the patient is looking for, and I cannot stress that enough. Because that is something, if you kind of include patients in the decision-making process, I will guarantee you that will spare you having to answer 3 phone calls from the patient for the next 1 week, which would help you conserve your resources too. The patient went away, fairly happy. I don't necessarily think that the person she saw on an urgent basis, and this is I'm using artistic license. She did not see an urgent provider on an urgent basis. But if you might be that person who's called upon to see this because the regular provider is not around, you may not have as much information about the patient. And considering those circumstances, I don't think the advice that was offered to the patient was necessarily, incorrect or insensitive. But there are certain benefits sometimes to knowing your patient's background. But there may be times when we may be flying kind of blind, or at least partly blinded, by virtue of not having known the patient very well.
There are some really great questions and comments regarding this case. So I'll go through those for you. But after that, I do want to go back. There were a few medication questions and comments from the second case that I'd like to go back to when we're done these. So a couple of things. One quick question. What medication was this patient in case number 3 on?
Okay. So I will actually give you some more background, which will help you in your decision making. One of the patient's diagnoses, in addition to mood disorders, is the patient actually has a history of borderline personality disorder. And I say that because a lot of times when you see that diagnosis pop up on your list of problems, that will probably generate something called countertransference, which is what the patient, the emotions the patient wrestles up inside of you. So my plea to you is, please don't be blindsided by your own emotions, when you encounter a patient who is seemingly a little bit difficult. But to come back to the question, so the patient is actually on an antidepressant called mirtazapine, which was pretty much maxed out. She was on 45 milligrams a day. So we didn't have too much leeway in that case. But what we had also been doing for a while now is we'd been augmenting the actions of mirtazapine with a medicine called aripiprazole. The brand name is Abilify, which is actually a second-generation antipsychotic. We weren't using it because the patient was psychotic, but there is evidence that you could potentially add medicines from that family to antidepressants to essentially boost the effect of antidepressant medication. So we were using it as an augmenting agent, and she was on a relatively smaller dose of aripiprazole, Abilify. So we were just able to increase that a little bit.
Thank you. So there's a reminder from Deidre. She said that we have to do more than just give resources. We need to engage with the patient as well. And that comment leads into a question that Erica Husser posted. And Erica, if you don't mind, if I put you on the spot, can you unmute your microphone and share that with us?
Oh, sure. In this situation, the interventions of mindfulness and grounding are beautiful techniques. And I wonder how there's a very large portion of the population that may consider these techniques of intervention woo-woo. I've heard that term thrown around. So I'm just curious to know how you might sort of absorb that observation from a client that comes in and says, well, I'm not going to do that. Or is a little bit reluctant to try it because maybe it's just culturally uncomfortable for them.
Right. So Erica and Deidre, thank you for bringing that point up. And actually, I did not elaborate on that earlier on because I wanted to be brief in my presentation. So often when I'm recommending these to the patients, I actually make them do some of these things in the office with me. And it's an intervention just like everything else. It may work, it may not work. And yes, it might be a little bit too new agey for some patients, and you respect their reluctance to try them out at times. But as is the case with most things, sometimes they're willing to go along with it. But if they are, I actually have them practice some of these interventions with me in my clinic. Now, again, the reason I mentioned these was if you're going to try and have them do that, this isn't going to extend your clinic time by 30 or 45 minutes. So these are very practical interventions. They are very brief interventions. A lot of times these interventions might be helpful. Now you have to be realistic, right? So if you're counseling a patient who is having panic attacks, I tell them it will take some time for these things to kick in. I counsel them about, what a panic attack feels like. So if you meet with people with panic attacks, the first time they have one, they essentially, for most part, end up in the emergency room because they think they're having a heart attack. But once they're more in tune with what a panic attack looks like, just knowing what's going on is actually a very powerful tool. A lot of times people will come and tell you, I had no idea what was going on. I felt like I was losing control. But now that I know what, X, Y, or Z feels like, I can identify it and then implement these other coping non-medicine strategies before these things escalate. Or in some cases, as Tim said, use that hydroxyzine as soon as I feel the onset of a panic attack coming on. So yeah, no intervention's perfect, but I think it helps if you are able to demonstrate that and work it out with the patient when they're in the office with you.
Thank you. And thank you, Erica. Sorry for putting you on the spot. So there are a few comments, and then I want to get to a question that came in. I think it's a really important question. So someone mentioned that that statement that was used, everyone is anxious nowadays, could easily have been misinterpreted. So while that colleague's intent was unlikely to minimize symptoms, just a reminder that we all need to be mindful of the words that we're using as well. And someone else is also saying to avoid using terms like mindfulness and just walk them through the breathing exercises so they don't get caught up in the woo-woo stigma that goes with that.
Yes, and actually, if you look at the field manual, for the psychological first aid, they will say, well, don't drown the patient in jargon. So yeah, guilty is charged, but yes, I assure you, when I'm with a patient, I don't tend to throw these terms around. You want to use language which is easily understandable, so that this doesn't sound like a concept that's out there. The other thing, if I may mention, is I deliberately worded case number 3 in a particular way. What you may not get sucked into is, if a patient is particularly unhappy with a colleague of yours, I don't think it necessarily helps the situation for you to jump in and badmouth a colleague. I did that deliberately over here just to kind of help illustrate that point. The idea is it deviates from the original purpose of the visit, which is, to give the patient some kind of relief. So just thought I would throw it in there and
Thank you.
get on my moral high horse. But
well, here's another comment or suggestion. So those who are very familiar with their patients, if it's an older or more conservative patient from a Judeo-Christian background, they like to use the idea of prayerful presence, seeking the presence of their God in prayer. And it's essentially, prayer is essentially a mindfulness exercise as well.
Yep, and yes, so it is whatever works for you, whatever has traditionally worked for you. So oftentimes, patients will say to me, my go-to person is my pastor, and if that works, so part of your assessment actually is to help identify not only what you could do for the patient, but also what's worked for the patient in the past. And I was talking to you about suicide risk assessment. Actually, for someone with particularly orthodox religious beliefs, that belief in itself is a protective factor against suicide. So if I'm with a patient who's telling me they're having suicidal ideations, one of the decisions I must make is, well, is this person safe to walk out of my office right now? And so you obviously asked the questions I told you about. The Columbia scale can help you organize some of those questions in your thought process. But then you have to look at, risk factors. Are there any statistical factors which would put the patient at a higher risk? Are there any modifiable factors? And did you do something about it? Are there any protective factors? So in this case, having a strong family supportive presence is a protective factor, as is orthodox religious beliefs, which would preclude them from committing suicide. Modifiable factors could mean if you have a patient who is suicidal with multiple medical comorbidities, I will often, while they're in my room, call up their family member and say, look, this is what we spoke about as part of our safety plan. He or she is going to approach you, and please make sure that the 500 medicine bottles are safely secured. Or as I said before, just have a friend or a family member hold on to their firearms till they're okay. There are some risk factors you cannot necessarily do something about because they're not modifiable. So if this suicidal patient is an 85-year-old Caucasian male who's just lost his wife of 60 years, that will statistically put them at a higher risk. So you use that information to inform your decision making, but it's not something you can really do that much about. So look at fixed factors, look at modifiable factors, document what you did to mitigate those factors, and look at protective factors and document them.
Thank you. So we have one more general question, and then before we wrap up, I do want to go back to that medication question. So one of our providers from the State College area is asking, do you have any specific resources or strategies for approaching mental health concerns with children during this time?
So full disclosure again, I'm not a child psychiatrist, but what I can tell you is that there are online resources. So the ACAP, the American Academy of Child and Adolescent Psychiatrists, has some resources. The APA website has very good information on how you could deal with different patient groups. The one thing to perhaps maybe bear in mind is that children might present with mental health symptoms in a way that is slightly different from adults. So, so an adult with depression might present to you, with a feeling of persistent sadness, anhedonia, which is basically the loss of pleasure and interest in previously enjoyed activities. With kids, that might manifest more as increased irritability and being more defiant. And again, so some of the resources that are in there actually do make the distinction between how children might present differently compared to adults.
Thank you. And if anyone has any resources or strategies, that focus particularly on children, please feel free to share them, and then we'll include them in our follow-up. So going back real quickly before we wrap up to another medication question and comment. So I'll read the question first, I'll read somebody's comment, and then I'll ask you to follow up. So Karen Anderson said she was not familiar with the VA guidelines on using benzo and PTSD. Is it okay to use them in acute trauma situations? She said in college health, they often refer young women after a sexual assault for short-term benzo prescriptions. She wanted to know if that was appropriate. And then Kelly responded and said that she's not a physician, so without discussing medications in particular, she's been trained to be cautious of benzos and some other meds because they can interfere with effectively processing the trauma. She's been taught that should be a cost.
Actually, that's one of the reasons why the VA usually, recommends against the use of benzodiazepine. So, to answer the first question, I've been in medicine long enough to know that you never say hell no to any option, but there are certain options where my threshold for using them would be a lot higher than others. So my threshold for using a benzodiazepine for someone with a trauma background would be really, really high. Have I never used benzodiazepine in someone with a trauma history? I'd be lying to you if I said I haven't. But again, I would use it very, very, very sparingly and with extreme caution. And not just because it can, come in the way of processing the trauma. We know statistically that people with a background of trauma are more vulnerable to drug and alcohol misuse. So again, you don't want to end up replacing one problem with another one. Now, I will give you an example. I do have a patient who has a history of very, very severe PTSD. And, having known this person for many years, having known that this person has never misused medications, there is a certain time of the year, every year, when this person's symptoms flared up because it's clearly related to that trauma. And we have come to an agreement where during that time of the year, I will briefly prescribe him a small dose of benzodiazepines with a very clear understanding that this is not going to turn into a perennial prescription, and that we will, go down once that event or the memory of that event has passed. Again, this is something I would do very rarely, and I agree with Kelly that really you want to avoid using benzodiazepine. Now, if that is the only option available to you to calm that patient down in terrible distress, I would use it, but I would certainly not give them a 3-month supply, or I would let them know that you get 10 tablets or 5 tablets and that's all you get.
Well, thank you so much for
actually just one quick comment. I think I'm assuming this is Jeff Wong, but he has a comment over there about the patient might think that a statement like everyone is anxious nowadays could be interpreted as minimizing the patient's concern. Ironically, that is exactly what the patient actually said to me. She said, I felt my concerns were just minimized. So there you are.
Yes, thank you. And thank everyone who participated and shared. This was, I think, a very valuable discussion. Just a few closing reminders. You're able to collect CME credits for participating. We send a survey out after the session. Please remember to complete one survey for each session that you attend, and you would be able to use the same link for each submission. As mentioned earlier, all materials are shared. Please consider submitting a case, and we hope you'll join us for our next sessions. We have one this afternoon at 1 p.m. regarding ICU care during the COVID-19 crisis, and then tomorrow morning, Saturday morning at 9 a.m., Dr. McGregor Skinner will be discussing home algorithms. So hopefully we will see you then. In the meantime, stay safe. Thank you.